Half of the morning session is officially wrapped. If you are feeling little sleepy, this is your cue to wake up. Just stretch a little, smile at the person next to you and get ready because the best is yet to come.
We stole your, we stole your morning hours. We stole your morning hours, hopefully not your peace of mind. So with that, we will give the further charge to Miss Krishna and Miss Forum. Please don't look so relieved. The sessions are there.
Hello everyone, myself Krishna along with my co-host Forum welcomes you all dignitaries. So moving towards the thematic sessions, we would like to invite all the chairs Dr. Nishit Patel, Dr. Samir Gami, Dr. Hasmukh Balar, Dr. Sumit Chaudhary. Please welcome them.
So presenting our next topic, practice changing updates, antibiotics and sepsis management, extracorporeal therapies.
Antibiotic in this sepsis is the mainstay. Judicious use is the only way. Other modalities are very few. Let's learn, is there anything new?
So to learn more about the topic, please welcome our eminent speaker, Dr. Raj RAWAL.
Of the practice challenging updates for the antibiotic and sepsis management by the Dr. Raj RAWAL. He is with a very good speaker. He has been working as a director and ICU of the emergency service in the Saraswati Hospital, Ahmedabad, and is a director of the Entel Healthcare Private Limited. And his area of expertise is mainly this life support system, clinical nutrition, and telemedicine. Sir, we will like to hear you from this stage, and the stage is yours. Thank you.
Hello. Good afternoon, everyone. Thanks for the nice introduction. I think looking to the audience, I am very happy. Now, so many conferences are being held every year. The success of conference is not a venue or not a food. It is a presence of people in the audience, and particularly between 12 to 1 in the pre-lunch session. That is very important. So thank you to you people for being gathered in a good numbers. Now, Manoj has taken few of my slides in the morning about extracorporeal therapies. I have to focus on sepsis and antibiotics and try to finish ahead of time. Next. Next. Sorry. So if you look at the sepsis recent developments, I think newer guidelines that come up in a 24, the sepsis guidelines, very few subtle changes in that. I think before moving in the lecture, let us elaborate that. So in a resuscitation, now initially there is a strong recommendation of 30 ml per kg fluids in the initial hours. Now it has been weak recommendation. So you have to tailor-made that things depends on the tolerance and response. That is a major change in the fluid response. Second, now they are more relying on dynamic compliance rather than static parameters. So leg raising, passive leg raising, stroke volume variation, pulse volume variation are more reliable markers for a fluid response. Balanced crystalloids are preferred over saline. So these are the few changes in the recent guidelines. In a vasopressors, again, NORAD is a preferred drugs, but then one significant change, if you don't have time, then you can continue vasopressors through the peripheral line. So there is no stringent guideline that you have to wait for a CEP line to start NORAD. So that is another change. Rest, I think, antibiotic, there is some change that we'll see regarding the timings. Source control is again the more or less same. You have a DVT prophylaxis, ulcer prophylaxis, glucose monitoring, organ supports. There are very few subtle changes which is not as significant to discuss. But then the most important change is post-sepsis care. So there is an huge briefing about the post-sepsis care in 2024 guidelines, that they have focused more on a socio-economical aspects and the decision making. And I think we are encountering in our day-to-day practice that now people are more vigilant. The relatives are questioning by having lot of knowledge from the Googles. So now all the decision making, we have to be more collaborative efforts with the relatives. We have to discuss everything with the relatives. And they have emphasized more in this guideline that the post-sepsis care is a very important thing. Along with that, very interesting guideline come from the WHO. So WHO 2024 guidelines, they emphasize on a lower socio-economical status to the middle class family. So I think the campaign of surviving sepsis guideline now reaching to the WHO. So that means it is the people are more aware about the guidelines. It has a more acceptance, and sooner they will come up with the broad guidelines that is more economical viable, and it is good for a country like developing countries. Third guideline come, that is from the Germany, that is S3 guidelines. S3 guideline has put more focus on individualized care. The early detection and diagnosis, that is fine, but then individualized, personalized care, and some interesting on a post sepsis care. So these are some new guidelines as far as the sepsis is concerned. Antibiotic timings, there is a small changes in that there is no strict 1 hour rule. It is not a dogma now. It is not a dogmatic rule that you have to just follow it. They come that if the sepsis without shock, then there are so many other causes that you have to rule out. So you can buy time to rule out the non-infectious causes of fever and sepsis, right? So you can wait for an antibiotic dose, right? So that is an important, I think, change in these recent guidelines. And culture, they have put more on a culture from class 2A, now they have moved to the class 1. That cultures is very, very imperative before starting antibiotics. So this is an important change in that. I just put this new antibiotic. There are so many other antibiotics coming up, but most of them are oral antibiotics, like nephromycins, or there are so many other cephalosporin. But as far as concerned ICU, very few antibiotic is coming up. I put this slide just to make sure that we don't have much store with us. So be careful of using antibiotic. That's why I put this slide. Now extracorporeal therapy, as we know that what do we mean by the extracorporeal therapy? I'm not going to the detail. But then it just helps to buy time for a native organ to recover. So these are a broad indication, we can say, for the extracorporeal therapy. We'll focus more on sepsis. And these are the different arsenals of extracorporeal therapy. I think Manoj has mentioned in the morning. This is a refreshment. Again, the renal support like CRRT, hemodialysis, SLED. Respiratory, we have a VV ECMO and a core. Cardiac, we have VA ECMO, ECPELA and tandem hearts. Manoj has mentioned LVAD. So though it is not a LVAD and IBP, they are very routinely, now we are using IBP very routinely we are using. LVAD is now coming into the practice. Liver support, MARS and DPMAS. We have a cytosob, toremacin and auxiliaries. Auxiliaries has a triple advantage, that is, it not only remove the cytokines, it also remove the endotoxins, and you can have a continuous renal replacement therapy with that filter. So that is a benefit of auxiliaries. And we have plaques. So these are the different arsenals of extracorporeal therapy. And we know that it based on this mechanism. We are not going, this is the fundamentals, like diffusion, ultrafiltration, convection, and adsorption. So these are the CRRT mode that with the ultrafiltration to continuous veno-venous hemofiltration, hemodiafiltration. So your ultrafiltration is just a diffusion, and then you have a, by means of convention, you have a CVVH. We know the difference, the blood flow in CRRT is low, diazolate flow is also very low, and that is continuous 24 hours. So that is very safe for a hemodynamically unstable patients. So CRRT mastering, again, we have to identify the right patient for that. Means it is not that you can advise everyone who want to do CRRT, right? SLADE, there are still good data that if SLADE is manageable, do a SLADE. So CRRT, again, that required a lot of logistics, a lot of cost, and the complication is also comparable. So it is not a magic things that you enroll everybody on CRRT. So the question is when to start CRRT. There are some interesting trials are there. So very important trials is START's trial, that is NEGM 2020. So they say there is an 20-day, 8 days mortality or benefit is there, but 90 days mortality is not significant if you do early. The ideal ICUs confirm that the delayed strategy is safe. The ELAN trial, that was a single center trial, and that was surgical ICUs. They claim that early is better. But again, this all trial, which we have mentioned over here, the comparative of all these 5 trials, if you look at, then there is no significant difference of having a early CRRT. So as I told you, you have to be very judicious of putting patient in CRRT. CRRT dose and anticoagulation. So this is a common practice that I think we are not going into the details. That initially we use citrate. There are very few indications for the heparin. So the dose is 25 to 30 ml per kg per hour to deliver 20 to 35 kg per hour. So that is a standard flow that we are using, and citrate is a first line anticoagulant that is to be used. If it is contraindicated, you can use heparin. I am not going into this detail. Okay, extracorporeal hemoperfusion. Right, this hemoabsorption, so that they absorb the toxins, the cytokines, and endotoxins. The cytosob and auxiliaries, as I told you that auxiliaries, in addition to cytokines, it also remove the endotoxins. Now there are different evidence which is available. The UFAS trial, UFAS and UFARA trial, they are very, very popular trial for hemoabsorption. So UFAS trial claims that there is an early mortality, early benefit, but again, 90 days mortality, there is no statistical difference. Same thing in a UFARA trial, there is no mortality benefit. Everybody claims there is a 28 days mortality or 28 days benefit are there. There is a reduction in NORAD support, there is a reduction in ventilator days, early discharge, but if you look at the 90 days mortality, there is no statistical difference. The CytoSoap meta-analysis that come up in 2022, I think so many of our friends from CytoSoap company, they are meeting up. But again, there is no significant benefit of all these filters. So there is no evidence for a positive effect of cytosoap absorption on mortality across a variety of diagnoses that justifies its widespread use in intensive care medicine. So this is an interpretation of a meta-analysis of cytosoap. So we have to redefine the signals. Where is a niche? Means we are not comfortable with our armaments that these are the available things. It is in front of our eyes, but we are not sure whether to use it or not. So that is a common question. Some relatives are always asking that, "Sahib, patient ave kasud nathi, je karu e karo." So we don't have any niche or very definite solution that yes, we can use this, right? Even the Tigris trial is also claiming, but then it is a very small study and it is not a meta-analysis that is confirmed that this is very, very beneficial. So we are very sporadic, as I'm sure so many of friends we are using, and patients are improving, but there is no definite trial which claims that it is the treatment for a severe sepsis or septic shock. Now we just move to the ECMO quickly. So VV ECMO we know that is for a ARDS, VA for a refractory cardiogenic shock, and eCPR that is for when there is a refractory cardiac arrest which is not responsive after 20 minutes. Then yes, you can put patient on ECMO. So there are evidence. The most important is Caesar trial. The Caesar trial, again, it is also not claiming that ECMO is a very, very beneficial for a patient with ARDS. So this trial, they have included a patient with a Murray score more than 3 and pH less than 7.2. And early transfer to the ECMO with a 90 days mortality is not significant, but then they claim one interesting thing, that with a high volume of patient at a ECMO center, the success rate is high. That means that the overall quality of care, supportive staff, your logistics are good at a large center. So the center which have a more than 20 or more than 30 ECMO per month, it has a good success rate. That is a interesting results or interesting point found of this Caesar trial. Again, eCPR, I am not going into the detail. Acapella is just like an LVD. There is an machine that was to be put into the circuit. Now the critical pitfall is these all ECT modules, they are also removing the antibiotics. So we have to think about the antibiotic dosages, particularly which is we commonly use like beta-lactams, vancomycin and aminoglycosides. So the most interesting is you have to have a therapeutic drug monitoring, which is unfortunately we are not doing routinely. So that is a gold standard, but that we are not doing. So there are some TDM guided suggestions says there is most of they suggest that there is no dose reduction is required. Just remember one thing, there is no significant dose reduction is required when patient is on extracorporeal therapy. right? Patient with a cytosol, patient with auxiliaries, patient with a CRRT. By and large, there is no dose adjustment is required. Now, the most important thing is stewardships, because these patients are very, very moribund. So you have to be strictly adhered to your antibiotic stewardship program, and that will not improve the overall success rate, but even sometimes it happens that you can reduce the usages of all these extracorporeal therapy. So this is gold standard de-escalation therapy. You start, you hit with the heart, you de-escalate, depend on the culture and sensitivity reports. And the important is duration of therapy. The dot is also very, very important, right? CRRT, mind well about the dosing errors. Filter lifespan is hardly, average is around 18 to 20 hours, right? That is, and so you have to take care about that. For a sustained change, you have a audit and feedback. Yeah, I'll finish in 2 minutes. And you should have a daily ID or pharmacy round. The barrier to implementation, all these ECTs, we know that lack of awareness and availability, high cost, evidence is still evolving. Still, you don't have a very standard evidence. Need expert dedicated training. Ethical dilemmas, when to stop. That is a big ethical dilemmas. Logistically and very labor incentive. Future direction, we feel that then we need smaller mobile integrated devices. We should have an automated closed loop feedback system for fluid balance, anticoagulation and gas flow. We have wearable artificial kidneys. Some company come up in 2020 with artificial kidneys. So maybe in the future, you may have that. You may have bioartificial livers, kidneys, totally implantable, and smaller compact version of ECMOs. So key takeaways, we know that antibiotic first, you have to use ACT very smartly, heme adjacent with a very caution, not for a routine sepsis, keep it reserved for a refractory sepsis. ECMO saves life, particularly in a high volume centers. Hemoperfusion for poisoning is definitive. We learn in paraquat poisoning tomorrow. And always remember TDM, your therapeutic drug monitoring, that is very, very important. So the modern management of severe sepsis and shock is a multimodal strategy. You should have a very vigilant about what is happening around you. Read about the latest guideline, read from your patients, read your local guidelines, and then decide. ECT are powerful adjuvants, but to be used judiciously. And success hinges on personalization protocols and a multidisciplinary team. Thank you.
Lovely, wonderful talk, Rawal sir. It's been very well said that it needs the multidisciplinary team approach. That's what we do in our ICUs and through the ICCM. Thank you. Floor is open for the questions from the audience if is there any there.
It's a combination of a question and a comment. So why do we think that the cytokine removal systems haven't worked? You know, if you look at the patterns of sepsis, the cytokine patterns, one would realize that it's a more complex than just a surge in cytokines. We have done a study, going to publish it, the cytokine. So very few patients now die of the early cytokine surge because our resuscitation protocols, our antibiotics, the way we manage initially, the deaths are very small. Actually, the more patients, and also the age group and the comorbidity of patients, more patients die later because of immune paresis actually. So initial surge of both pro and inflammatory cytokines happen, but there is a persistent fluctuating predominant anti-inflammatory cytokine surge which happens in those who die. So more mortalities later, and that's what these cytosol systems are. They look good early because when you remove a lot of cytokines, obviously that surge reduces, your vasopressors go down. So most of them have shown a mortality benefit, not even 28-day, 14-day mostly. But beyond that, it doesn't, because actually the immune paresis takes over and the death happens because of immune paresis of one form or another, which could be expressed by an HLA-DR expression or the anti-inflammatory cytokines. So that's the reason why eventually I'm sure when we do more precision medicine, when we have targeted therapies for different subgroups, we may get benefit in subsets. But at this present moment, that is the reason probably we don't get the benefits. So utilizing cytos or any of these removal mechanisms is probably not greatly useful right now. Sometimes we come under pressure because of the fact that the family, as you rightly said, asks, "Hi kuch to karo," right? So that is not good science.
No, but I think you're right. I think most of studies, they have mentioned that the 28 days mortality is reduced, means, and practically we have seen that there is reduction in the dose of NORAD, the ventilator requirement is reduced, but then maybe the immunoparesis plays a role for a significant mortality later on.
Thank you, sir.
Thank you.
Thank you so much, sir, for such a wonderful session.